Hi everybody. So hopefully you can hear me. Welcome and thanks for joining us this afternoon to our major trauma webinar briefing. Probably, I don't know if some of you will know me. My name is Mark Henwood, Deputy Medical Director of Hywel Dda, and we've got an hour and a half today. And clearly this is very important because the South Wales Trauma Network is going to go live on the 14th of September. And this is all really positive and something that I'm sure that we've all been really looking forward to. So the aim of the session today is to really make sure we're all aware of all the important operational information that the network has. Importantly, the benefits of the trauma network and how the network is going to operate, and alter patient flows from the 14th of September. There will be specific pathways and a new local major trauma policy and a rural trauma facility procedure, and Stuart will talk us through that today. There's probably too many of us for us to all introduce ourselves, but I think there's three people I would like to introduce today. So Dr. Stuart Gill is here with me in Carmarthen. He's a consultant anaesthetist and he's the Hywel Dda Major Trauma Clinical Lead. Dindy Gill, you can give a wave, Dindy, if you want. There we are, there's Dindy. He's the consultant in emergency medicine and the clinical lead for the South Wales Trauma Network. And Rachel Taylor is also here with us in Glangwili. She's the Trauma Operational Network Manager for the network. So the plan of action in a couple of minutes is Stuart's going to give a presentation, and after that we will have a Q&A session. Now, if I can ask you, if during the presentation you have any thoughts or questions, if you put them into the chat function, then Emma's going to be keeping an eye on that for us, and then we'll pick up some themes at the end. But we'll just try and run through the presentation rather than stopping as we go along. But then in the Q&A function, if you can raise your hand, then we'll try our best to make sure that we get to you. Though it may be difficult to do it in a fair order if there's lots of people. Obviously, this is all over Teams today, and as you know, sometimes Teams is great, sometimes it's less great. And I'm told there are network problems today, so it may be that reception may come in and come out. I did mention to you at the beginning, those who came right at the beginning, but those who just joined, we are recording the session today, and that is with a specific for a specific reason. That's basically because we want to share the information that we're providing. So please keep your speakers on mute. I can see you're all doing that, and that will then stop any feedback. The aim is that we're going to go till 2 o'clock. I mean, if we overrun a little bit, that's fine, but hopefully by 2 o'clock we'll all be done and dusted. So I'm going to hand over to Stuart now, who's got a presentation. So sit back and enjoy. Stuart.
Thank you, Mark, and thanks everyone for joining today. Hopefully you'll find this very useful and interesting, and be ready for our go live in September. Just to check, I can be heard okay? Nods or shakes will be fine.
Thumbs.
And that you can see the slides, so it looks like that's coming through. Okay, so this is the introduction to Hywel Dda's contribution really to the South Wales Trauma Network. Just as a quick overview of what we're going to cover today, a little bit as far as the background of the development of the network, its structure as it stands now ready for go live, and a little bit of the story as to how we've got here. That will be fairly brief. There is a very good video that's been put together by Dindy with the network that will give you a bit of a more broader overview of its development. So as I said today, very much focusing more on the Hywel Dda contribution and how things are going to work for us. We're going to cover primarily the clinical pathways with a focus specifically on repatriation and rehabilitation, the acute pathways and accessing resuscitation and definitive care for patients in the early phase of their injury, cover the local policies and procedures that Mark's already mentioned and how those are going to assist with the pathways, and highlight to you the way local clinical governance is going to work around major trauma. So first off, why do this? Well, there's clear evidence of improvement in patient outcomes from a point of view of mortality and functional outcomes from data from networks, trauma networks, trauma systems throughout the world. More specifically, from the UK, the Lancet published in 2019 data showing almost 20% mortality benefit for patients who have suffered a major trauma and are treated within a trauma network. And that didn't matter which hospital, type of hospital they're treated within the network, there was a net gain in terms of mortality. Trauma networks have been in existence for 10 years within the UK, since 2010 in London, and then the rest of England joined in 2012, and then North Wales has been served by the North West Midlands Trauma Network since 2013. So we're quite a way behind in the south and not served as well as much of the rest of the UK yet. As I mentioned earlier, there's a specific presentation around the way the network will work and a broader overview available via the link there at the bottom of this slide, where you can get a little bit more detail of the network perspective. So as we've said, go live is the 14th of September, so not very far away now, and people are working very hard to get things fully set and everyone aware of how this is going to operate. I said I'd touch on the way this is developed to the point we're at now. So back, this has been underway for several years, I think as early as 2016 or so, but started with a vengeance in 2018 with a South Wales consultation on whether a network should be set up and where a trauma centre should be sited. And the outcome of that was that UHW in Cardiff would be the trauma centre for the South Wales network. There then followed a public engagement which we held within Hywel Dda in the autumn of 2018, where the designation of hospitals within our health board was discussed, and it was settled upon Glangwili being the trauma unit for the health board, and that is an interim measure until such time as the new hospital in the south is set up, at which point that will become the trauma unit. Following that, extensive development of a network-wide business case with contributions from all health boards, and the development of the services that were required for each of those health boards and each hospital. The operation delivery network is now set up, and you've briefly met Rachel, who's managing that. And then a whole host of policies, guidelines and governance structures have been developed to help guide and give structure to the way the network is intended to work and function. So just moving on to some terminology. So a network is made up of different levels of hospital that support each other and have specific functions. At the centre of the hub and spoke structure is the major trauma centre. As I've mentioned, that is UHW in Cardiff for both paediatric and adult trauma. And essentially that is a hospital equipped with all the tertiary services required to allow management of all types of trauma and multi-sister trauma definitively. The next sort of level out in that hub and spoke model are trauma units supporting the trauma centre, which are specifically equipped to meet specific quality standards that are set across the UK to allow appropriate and quality resuscitation response, the initial management of patients who are thought to have suffered a major trauma, and the definitive management of some patients with single system trauma. And as part of that, there are specific resources that have been put in through the business case to allow those hospitals to meet those standards. The next level out, and this is fairly unique, is unique, and is a new designation in the South Wales Trauma Network, specifically for Hywel Dda, is the level of hospital which is termed a rural trauma facility. So for the network purposes, this is a hospital that, because of its relative rurality, geographical isolation, is more likely to see and need to resuscitate and stabilize patients who've suffered major trauma than the alternative designation, which is the only other designation in English networks, and that is local emergency hospital. The definition of a local emergency hospital is a hospital with an emergency department and appropriate supporting services, and it doesn't have those specific trauma-related quality indicators designated that the trauma unit does. So in recognition of the fact that Bronx Ice and Withybush are significantly further from the trauma centre and a trauma unit, have longer travel times, and it may be less appropriate for paramedic crews to bypass them, they have been given this alternative name in recognition of the fact that they will still need to receive, resuscitate and stabilise more major trauma than a typical local emergency hospital would. And those hospitals are going to be specifically supported in that role by the health board and by the major trauma multidisciplinary team that will be based in Llangley. So looking at the structure as a whole and focusing on the patient pathway really, overseeing the governance, training, education, data to support development of the network and quality improvement is the operational delivery network, which has representation from all the health boards and clinical leads in the various areas that are focused on, such as paediatrics, education, rehabilitation, etc. So they have overall responsibility for coordinating the network. And then at a more operational level, we have in this schematic the pre-hospital phase, the potentially receiving hospital with real trauma facilities and trauma units, and then ultimately the major trauma centre at the right of that site. So coordinating, providing support to those patient pathways is the trauma desk, which is run by the Welsh Ambulance Service, has specifically trained specialist trauma paramedics, and is supported by EMERTS and the paramedics, critical care paramedics that run the EMERTS air desk. And their role is primarily to support WAST with clinical decision making and support their interpretation of the major trauma tool, and then onward patient conveyance to the most appropriate place, as well as to coordinate calls, either involvement of EMERTS to those patients pre-hospitally, as well as in hospital. And it is through that desk that all calls involving the referral of patients, particularly urgent, hyperacute and emergency transfers to the MTC, that will be passed. You can then see that there's sort of three entry levels to the network really. So from the pre-hospital phase, then patients may well go direct to the MTC, dependent on stability and travel time. That travel time will be less of an issue if EMERTS are available, either because they're able to transfer the patient more quickly by air, or stabilise at scene and transfer direct to the MTC. And then in the dashed lines, you can see the entry to our local hospitals. So dependent on level or severity of injury determined by or guided by the major trauma tool, patients may flow into the rural trauma facilities or into the trauma units, and then potentially with onward transfer to the next level of hospital, if you like. I mention now the specific inputs to those hospitals. So in the trauma unit, we have, and successful recruitment is ongoing to these roles, the major trauma practitioners whose main focus is the acute and immediate in-hospital and sort of post-acute care phase, but also keep in touch with the MTC and coordinate patients that have gone in there and may well be returning to us. The rehab coordinators working very closely alongside the major trauma practitioners, whose role is very much more at the end phase of the acute care and onward rehabilitation. We will also be having rehab consultant dedicated sessions in Health Board, and I'll come on to that later. This is all that is coordinated through the TQIC, the Trauma Quality Improvement Committee, again, which I'll cover in some more detail later. At the MTC, the big changes really are the single point of access, and that will be through the emergency department for certainly the hyperacute and emergency referrals. And the point of contact via the trauma desk is the trauma team leader, who is an emergency medicine consultant available 24 hours in the MTC. And the other big change is that a polytrauma unit or a polytrauma ward has been developed in UHW, where those with particularly or multi-system trauma will have their care coordinated and better input from multiple teams and better coordination through multiple teams. And I've missed on there the rehabilitation pathway, so that's shown in green. We will come on to that in more detail later, but you'll see that that is either home direct through the trauma unit or back to a local hospital closest to the patient's home. Just to cover the local clinical governance processes and resources before we go on to more specifics around patient pathways. As I've mentioned already, there's a multidisciplinary team being brought together that will coordinate learning and quality improvement, as well as those day-to-day functions of keeping track of patients' needs and onward pathways. This is intended to function over multi-site, so all those hospitals receiving or dealing with patients with major trauma within OLR, intended to promote network-wide learning and coordinate and deliver training to our staff. And this is done through the TQIC, as I've mentioned already, the Trauma Quality Improvement Committee, which is a term that lines up with terminology used by and developed by the network. So this relatively busy schematic just gives an idea of how that's intended to work. In blue, you can see the reporting lines. So this starts with a major trauma core MDT, so that made up of those roles I've already described, meeting weekly to discuss admissions within that week, highlight any cases that may need a little more in the way of scrutiny, and discuss patients who may be returning to the health board and any troubleshooting that we need to do early. That then feeds into a trauma unit, major trauma M&M, which we will be holding monthly and will be hosted through the emergency department in Glanwilly. And that then feeds on into the Trauma Quality Improvement Committee. Feeding into both of those levels, the weekly meetings and the monthly meetings are highlighted sources of information. So for the weekly meetings, live case identification, and particularly the major trauma practitioners will be attempting to keep tabs on those patients admitted on a daily basis who may well be identified as having suffered major or intermediate level trauma, and regular interrogation of the DATIC system, which has already been set up, essentially flagging those patients who've been entered into town or identified as town positive and have had a DATICs raised, and we're looking at those to see whether there's any specific major trauma related issues. And then the TRID, which is will be a relatively new term to those working here, and that's trauma related incident database. And that is a network hosted reporting system separate to DATICs and specific for trauma, and will be in place until the national review of DATICs allows better sharing of information. And the idea that that's a rapid reporting system that allows learning across the network, where something has been identified that is more than just local or may be of benefit to others to learn, and gives a more rapid awareness of those issues to the network than the reporting system that you can see there. We'll then be holding the TQIC meetings on a quarterly basis with representation across specialties and across sites. So there'll be rural trauma facility representation of those, as well as each specialty within the TU, including rehabilitation. And as well as those, the M&M cases that we flagged with learning points reporting into their source of information will also be the TARN reports, so the 3 annual clinical reports, TU dashboard, and a report that we can run which looks at patients with an ISS, so by definition major trauma, who remain within health board and MTC, just to check that that was appropriate and we've given good care to those patients. And then finally, feeding into the TQuick, we're asking for specialties within the 2 rural trauma facilities to flag made cases that they've discussed in specialty M&Ms that have any element of major trauma and major trauma learning, to flag those and bring them through to the TQuick. For outputs, the TQuick reports to the Health Board Operational Quality Safety Committee locally, and then into the quarterly South Wales Governance Committee, and we'll be submitting cases discussed at M&M and learning points thereof through into the Governance Committee, and taking learning back from other health boards and across the network. And other outputs are quality improvement initiatives developed as a result of learning, and we're intending to publish a lessons learnt bulletin on the major trauma intranet, which is going live as of today, to allow sort of rapid dissemination of particular lessons learned from M&M and other discussions. So that takes us on to the specifics of patient pathways, and I've started with repatriation and rehabilitation because of its correctly identified importance. I suppose I'd say relatively unique to the development of the South Wales Trauma Network. A lot of learning's been taken from England and their development, and emphasis put on the need for, from a patient point of view, the need to get home closer to family and to assist with the psychological recovery from major trauma, but also to assist the major trauma centre in providing good quality care and not having its beds filled with those who are ready to start the next phase of their treatment in terms of rehab and repatriation. So looking at the numbers, I can't give you any hard ones, but it is estimated that in the region of 20% of admissions to the MTC will require ongoing inpatient treatment. So a fairly small proportion, and of that, a proportion will go on to specialist rehab care, and a proportion will simply need ongoing medical care and reablement to get them home. It is rare, I should point out, to require repatriation to intensive care. Most patients coming out of the MTC will be ready for ward-based or home or community level care. So for rehab, patients fall into 3 main groups, or we're considering them in 3 main groups. And those are those that require ongoing medical specialty input and level 2B rehabilitation needs. So that is, and for those colleagues who work in critical care, this is a flip from the designation for critical care. So level 1 is the highest level of rehab need, and level 3 is the lowest. So 2B, significant, some specialist therapy input, but not much in the way of multi-therapy requirements. The second patient group we've highlighted there are those who are waiting a bed for specialist rehab in one of the specialist rehab units, that being Rookwood or Neath Talbot, and those being designated level 1 or level 2A rehab, but currently not fit from a medical point of view, so need a little more in the way of settling of the acute sequelae of their trauma or any complications they've suffered before they're ready for rehabilitation, or simply awaiting a bed there and no ongoing trauma specialist care required. And then finally, as I alluded to, we're expecting a larger number of these patients, those patients requiring reablement or rehabilitation, and typically thinking in the older population this is more likely, or requiring a package of care prior to discharge. So this may be patients coming back to the rural trauma facilities, possibly even non-trauma designated hospitals or community beds. There's an automatic repatriation policy being agreed through the network that sort of hooks onto or is appended to the All Wales repatriation policy, and that is that we have undertaken to accept patients back into the health board within 24 hours of them being identified as ready for discharge from the MTC. And this is really with that focus on patients coming back for care closer to home and ensuring that the MTC doesn't end up with insufficient capacity for patients with acute injuries. In order to facilitate that, and that does sound a slightly shocking undertaking to some, this really is a core role of that trauma MDT that I've described. So the major trauma practitioners and the rehab coordinators regularly being in touch with the MTC and keeping track of our patients who have been treated in the MTC through the major trauma patient database. And they can see from point of admission really a predicted discharge date and predicted requirements at discharge to allow some planning locally and preparation for where those patients may be received back to. We've developed a major trauma policy, as has been mentioned already, and as part of that we've predefined specialties into which those patients will return, and in general it's expected that those ready for discharge from the MTC will come back under the consultant on call for that specialty at that time. And that designation is really dependent on the predominant injury or injuries with ongoing rehab or care requirement. So in summary, those with abdominal, thoracic or vascular injuries will in general come back to general surgery. With musculoskeletal injury, including pelvis and spine, come back under orthopedic. And those with purely isolated ongoing traumatic brain injury issues and rehab for that with some medical input required will come back under medicine locally. That's not to say those patients will necessarily stay under those specialties or in the hospital they come back to, but this is intended to facilitate that offloading of the MTC and to facilitate getting patients back closer to their families. There's also the special sort of circumstances that we need to consider, and particularly highlighted there patients with tracheostomies and needing ongoing care. There's an undertaking from the senior nursing management and rehab staff that there will be specific support put in place for nursing staff looking after patients with tracheostomy care, and support from those already trained in doing this, and there's training packages available through the network to support this. And then finally, elderly patients, which I've already indicated, group 3 of those repatriated will predominant. There may be a need that those go directly under the care of the elderly consultant, perhaps not in one of the trauma designated hospitals, depending on their ongoing needs. Underpinning all of this is the support of the rehab coordinators, who will give both hands-on ward-based support and advice, and coordination in keeping track of those patients and their needs, providing them with a key worker, and the input from a rehabilitation consultant. So we are expecting, as part of the network and the business case, to have dedicated rehab consultant sessions in health board to support specialties who may not feel 100% confident in all of the needs of patients repatriated. I've alluded to this somewhat already, but just to underpin it, this is a schematic lifted directly from one of the major trauma network policies, and it highlights streamlining of that process, getting patients back in health board when ready. So you can see there's mention of the database, so that we can keep track from virtually point of admission to the MTC, look at estimated discharge dates and likely requirements at discharge. That will be monitored by the major trauma pracs and rehab coordinators. They'll liaise with inpatient teams to warn them of a expected return of patients, and they'll liaise with the bed management teams to ensure they're sited and preparing for return of those patients. So we should be well aware of these patients coming back, and shouldn't be a surprise that we're told they're ready and we need to sort it within 24 hours. That should be well planned and well anticipated. I do need to mention at this point that there is an escalation policy to that repatriation process, including escalation through trauma clinical lead and hospital exec management layers, but ultimately there is the option to the MTC and the network that patients are returned directly to ED by ambulance if after 72 hours a bed hasn't been identified and repatriation sorted. Would expect that to be very rare to be enacted, and if it is enacted, it will invoke a serious incident review through the network. So that covers a very quick overview of the repatriation and rehabilitation pathways. I can't stress enough that the input of the rehab coordinator, major trauma practitioner and the rehab consultant really are vital in assisting to deliver that, but also those pre-agreed specialty receiving specialties, so that really the only issue to sort, which with prior notice should be easier, is a bed space for patients to come back to. So takes us on to the acute phase and how we deal with patients in greatest time of need, really, and what a lot of people focus very much on when they're thinking about a major trauma network. In the we're going to look at this in a couple of different stages, and starting with pre-hospital, to assist paramedics with decision making and appropriate triage of patient. A major trauma triage tool developed, and this is very similar to several trauma triage tools in use across the whole of the UK. Worth remembering that entry to this tool is suspicion of major trauma, so really is led by clinicians' assessment of what has caused this patient's presentation. There's clinical advice available via the trauma desk to assist paramedics in interpreting patient findings and how they fit into this tool. And it is a 4-stage tool, and I've got another slide where we can highlight those different stages, but essentially from left to right, reducing sort of importance of that tool. So triggering in the first and second column really do suggest a need to triage as major trauma to a MTC if possible. There's another aspect to the tool, and that is the silver trauma tool applied to patients, older patients, and the entry to that is patients who are suspected of a significant trauma, have not triggered on the general major trauma triage tool, and are over the age of 65. And that takes into account altered physiology, potential for medications affecting assessment, and the fact that as patients get older, they are more frail and more likely to suffer significant multi-system trauma from relatively low mechanisms of injury. As I said, it's a 4-stage tool, and as you can see there, hopefully a bit better on that slide. It goes from vital signs, so significant abnormal physiology, through assessment of anatomy of injury and those injuries that are more likely to require specialist input, through a mechanism of injury, so descriptions of mechanisms likely to result in significant polysystem trauma, and then special considerations, those particularly being those over 65, children, and pregnant patients, or those with abnormalities of coagulation. So already covered this to some extent, but the Silver Trauma Triage tool, designed to increase awareness of the fact, and this is underlined really by data from Tarn, of the fact that a lot of older patients do suffer significant polytrauma as a result of relatively low mechanism injuries. Things to highlight in this are that there's a raised threshold of systolic blood pressure for these patients, so those presenting with a systolic of less than 110 rather than less than 90 in the main triage tool, and emphasis again on anticoagulation. In the anatomy phase, an injury to more than identified to more than 2 body areas, a emphasis put on suspected shaft of femur fracture and open fractures to wrist or ankle, as indicating potential for major trauma designation. And then a change in mechanism, fall down 3 or more steps, and any pedestrian or car versus pedestrian versus car or cycle. This does not necessarily mean that those patients triage to the MTC, but a big emphasis is that these patients should have major trauma team call-outs placed when they're triggering with this tool, and should have early access to polytrauma CT to fully define the extent of their injuries. And again, I want to refer to the Tarn data that has shown that there's a tendency for us to miss these, particularly of note rib fracture and thoracic injury, coexistent with other more common frailty fractures. So, alluded to this somewhat already, but stage 1 and 2, typically patients would go direct to an MTC if they are within 1 hour or thereabouts of travel time. So for our patient population, pretty rare that we're going to have patients falling into that group. There's an emphasis on the involvement of EMIRTs where the travel time from scene is greater than 60 minutes, and WASC colleagues should be strongly considering that, particularly triggering at stage 1 and 2. And that transfer or transport of patient a significant distance has the caveat that it is only if their airway is adequately protected, they're not suffering from significant hypoxia, and they don't have significant circulatory compromise, all of which are not responding to simple measures or measures available to the ambulance service. So if patients have presented with significant airway compromise, hypoxia, or circulatory compromise that WASC colleagues are not able to treat or stabilise, the direct to MTC doesn't apply, and it's the emphasis on accessing immediate advanced medical intervention to help correct those aspects and stabilise for onward transfer. So this is where EMIRTS really does come in, and the advice to WASC colleagues is that they will be supported in waiting on the scene up to 15 minutes for EMIRTS to arrive. So should obtain an ETA for EMIRTS. If that's less than 15 minutes from the point of being able to transfer the patient, they should await and for that help through EMIRTS. If EMIRTS are greater than 15 minutes away and they are ready to move to hospital, so the patient is packaged and in the back of the ambulance, then it's advocated that they do so. And then ideally it would be towards the trauma unit in Glengley. Now, that is not necessarily that the ED or the clinicians there are better at resuscitating those patients, but it's significant that by going to Glengley, those patients are moving closer to the MTC, which is likely where they're ultimately best served. So again, a 15-minute rule on that. If the patient is being picked up at a point where the travel time to the trauma unit is less than or equal to an excess of 15 minutes over how long it would take them to take to the rural trauma facility, then they should go to the trauma unit. If the travel time to the trauma unit is greater than 15 minutes in excess of the time it would take to travel to the rural trauma facility, then paramedics will be supported in going to whichever is the closest hospital. That's a bit of a long-winded explanation, but hopefully you get the idea. If safe and within a reasonable travel time, patients should be travelling towards the TU in order to facilitate more rapid onward transfer to the MTC. Alongside that, and I'm not going to talk you through specifically all of this flowchart because the scribes are already discussed, but specifically, it's important that EMIRTs are kept updated as to that patient's need, where they're going, and may well consider going direct to the hospital to liaise with hospital teams or rendezvous with the ambulance to facilitate stabilisation and move on. Already covered this really when we're looking at the picture of the Silva Trauma tool, and as I've said, a focus really is on lower mechanism causing significant injury, that physiology and pharmacology alters signs, and that we really should be focusing and emphasising trauma team activation for those triggering on the Silva Trauma tool in order to expedite access to CT. So we covered the pre-hospital phase and now looking at the emergency department phase. And this is best outlined really, if you want to look into it a little bit further, in the rural trauma facility procedure that is available via that intranet page that's the start. So we're looking to better develop and better underline the structured trauma team response. There's agreed network activation criteria, including activation for Silva Trauma, and those are available again via the intranet site, links to the Major Trauma Network internet site, which I don't think is live as yet, but will be soon, but also via the induction app, so hopefully some colleagues will have that, and there's a QR code at the end of this presentation that will give you a link to the guidelines and the policies. There's an undertaking and a specific quality indicator for TUs that an ST3 or above or equivalent will be the trauma team lead at the TU and should be the same at the rural trauma facilities. Accepting that we don't have emergency medicine middle grade cover guaranteed throughout the night, the process of the agreement is that there's inpatient specialty backup for that, and in Glangwili that is the surgical middle grade tier. When patients are arriving or being brought in clearly unstable or clearly polytrauma, WASH colleagues have agreed that where at all possible they will remain with the patient, ideally for at least 30 minutes to allow for decision making by that receiving team and potentially to facilitate early onward transfer with or without the assistance of EMIRTs, and not run into that problem that I'm sure we've all experienced of having the patient ready, waiting for the referral, and then having to wait a little longer for an ambulance to come and collect. So ideally the treating crew will be able to facilitate that onward transfer, but obviously there's a time limit to how long we can take paramedics out of their response sort of mode. There is, as I've said, potential for EMIRTs to attend without any referral. So if this has been picked up by the trauma desk and EMIRTs sent, but the patient's in that category where WAS colleagues feel they are not able to wait and the response is likely more than 15 minutes, they may well come to hospital, but EMIRTs may follow. It's well worth colleagues on receipt of a trauma pre-alert that suggests a patient with a high chance of needing onward transfer, making a call to EMIRTs to flag and make sure they're aware and find out if they're on the way, or make them aware of potential referral coming their way. And the real benefit from that is EMERS staffed by clinicians who have greater exposure to having to deal with major trauma, greater frequency of dealing and providing resuscitation to major trauma, and they're able to expedite that secondary transfer to the MTC. So this is a flowchart taking out of the rural trauma facility procedure, describes that emergency department pathway. It's a little too small to see in this presentation, but really just to flag that as a resource to you, again, available via links at the end of the presentation. So that brings us to the referral pathway, and for me this really is a sort of linchpin of the whole of the network process. So patients grouped for referral purposes into three, those being hyperacute, and essentially those with ongoing resuscitation requirement, for example hemodynamic compromises, transiently responding to blood resuscitation, or patients with a neurosurgical emergency requiring urgent craniotomy fit into the hyperacute designation. And then similar but with slightly less urgency for transfer is the emergency group, so those stabilised but with clearly defined polytrauma or severe single system injury that are better suited, better served in the major trauma centre. Both of those groups are a single point access, direct referral to the trauma team leader in the emergency department in the MTC, and they are contacted via that number, which is also available on the trauma triage tool and via induction app for ED to ED transfer, and that should happen rapidly based on the TTL's discussion. Should note that for the hyperacute it is purely a TTL decision. For the emergency pathway there is a window of 30 minutes for the TTL to discuss with inpatient teams if there's any uncertainty as to potentially futility or whether or not that patient is suitable for MTC care, but that is limited to half an hour. So if you discuss with the MTC TTL and they feel they need some further inpatient support for the decision, they will be getting back to you within half an hour with a decision. And then finally, group 3 is the non-time critical patient group, and that's those who are stable but require definitive care under a tertiary specialty, and that will be by, as existing to some extent, specialty referral with some e-referral being developed, but also with the ability to escalate. So if your patient hasn't been accepted into a bed and been transferred within 24 hours, then there is the ability to call the TTL in the emergency department in the MTC and arrange ED to ward potentially to ED transfer. So it's the reciprocal really of that automatic acceptance from a rehab point of view. Just take the opportunity then to flag to you the standardised network documentation currently in the final development phase. It's been out from me to some colleagues within the TU, and I believe to some colleagues out in within Bush and Bronglice for comment. And this really is a well-structured document, gives a standardised method of communication across the network really, and will follow the patient through to the MTC. But it also gives good quality data capture for TARN, and I haven't mentioned, but one of the major members of the sort of multidisciplinary team in the TU is the TARN coordinator, who we've had in post since January, and really key to showing how we're performing and highlighting areas that may require quality improvement initiatives. So important that we use these documents for patients admitted with major trauma or suspected major trauma to facilitate that quality documentation. So that's us at the end of the presentation. In summary, we've covered an overview of the structure of the system and how the ODN provides oversight, coordination and governance. We've highlighted the automatic acceptance along agreed pathways, both at the acute end for patients needing access to the MTC, but also for repatriation and returning patients with care closer to home at the earliest opportunity. And highlighted some of the resource that's gone into this. Further resources, the network presentation that I spoke about earlier, that there's a link to earlier in this presentation, the Major Trauma Intranet page, which is Health Board hosted, which will contain links to the South Wales Trauma Network internet page and policies and guidelines which can be accessed through that or through Induction app. And training. So there will be a whole host of online resources released soon from the network, including a set of videoed training videos which are based around the TREATS course. And we're hoping to do some face-to-face workshop and moulage type training in the new year within Hywel Dda. Those are the two policies, the policy and procedure that I've spoken about and that are accessible via the intranet page. And there's a slide just summarising all of those resources with links for you. Thank you very much. So we're moving on to the Q&A now. I think we're going to ask Emma just to come in with themes of questions and see if we can try and cover those relatively broadly before we open it up to the floor.
Thanks. Yeah, great. Thanks. That was excellent. I beat you to it. We're all fantastic. I was keeping up with the chat, and I saw I was going to. I know Dindy did come in about the silver trauma, but I just wondered whether there was anything else you'd like to add at this point, Dindy.
No, nothing addition for me. I think in relation to silver trauma, I think the key thing is this isn't about necessarily triaging patients with silver traumas directly to the MTC. This is about increasing awareness of silver trauma as an entity and the specific nuances around the elderly population, particularly in relation to the physiology and the mechanisms of injury. And I think it's important for all of the EDs in the respective hospitals to make sure that their triage nurses are aware of the nuances around silver trauma, and if in doubt, do put a silver trauma team activation out. The silver trauma team is effectively the same as your adult trauma team, but it just means that these patients get early recognition, identification of injuries, and their trajectory through the hospital pathway is often then a lot smoother.
Great, thanks. And Rachel, did you want to add anything at this point, or you're okay? Yeah. Good. Okay. So I saw that Nikki had answered asked a few questions. Are you happy with those responses, Nikki? Yeah, great. Okay. So, Emma, I haven't missed anything, have I, on the chat?
No, there was nothing else.
Great. Okay. So we have got 30 minutes if we need it. So if you would like to raise your hands, I mean, you can put stuff in the chat, and Emma is still there. But if Nicola, straight in. Right. Okay, Nicola, over to you.
Hang on.
Oh, sorry, I think you're on mute. It came off mute and then went back on again.
There we go.
Would there be a situation envisaged where there would need to be a transfer between a rural unit and the trauma unit at Glangwili?
Yes, potentially. For those patients who we would expect to try to cohort those patients with major trauma who need inpatient treatment within our health board, but to some extent a patient by patient decision. If it's a significant chest injury that's got potential to deteriorate, for example, or a head injury that does not need that needs inpatient observations but is deemed as having potential to deteriorate, again with the thought that they are moving closer to the MTC, and on the basis that the network is on the premise of cohorting injury together, cohorting patient groups together, helps deliver higher quality system care.
That's great. We already have an issue with transfer of children who need transfer personnel who are medical rather than paramedics. The health board would need to ensure that we have an adequate system to transfer such children then.
So from a major trauma point of view, would very much expect that if a patient is needing a medical escort for transfer, it's highly likely that they'll be heading towards the MTC. And in the majority of cases, it's likely that they'll be suitable for an EMERS transfer. Can't legislate for every possible permutation, but that is likely. In the rural trauma facility procedure, hopefully you'll pick up, it does state that EMERS cannot be guaranteed, in which case it's expected that local teams will provide the appropriate inpatient specialty to transfer that patient, whether that's anaesthetics, critical care.
Anything else you want to add, Nikki? Or okay. So, any other questions, guys? Or any other points anyone else would like to make? It's because of Stuart's excellent presentation. Oh, Janice. Hi, Janice. Would you like to come in?
Yeah, it was just one question about repatriation pathways, and particularly around the one around the brain injuries pathway. I'm just wondering, from a health board perspective, has it agreed a particular pathway for those patients, given the clinical input that how it's distributed across the health board?
Yeah, so acknowledging that it's a difficult position and no individual specialty feels they have the appropriate background training in head injury to meet the criteria that's set out in guidance. However, in local discussion within Willie, we've agreed that it's appropriate for such patients to come back under the medical take, because likely the ongoing requirements most appropriately fit with physicians, but key and the complexity of these patients really is around the rehab need, the post-traumatic psychological and behavioural and cognitive aspects, and that really is why those rehab consultant sessions are a core part of the business case and really vital to helping to deliver that.
Great, thanks.
I think Dindy's got a comment to make on that.
Yeah, it's just to echo really what Stuart said in relation to those sort of high-end, head injured, spinal injured patients who may need to come back whilst they're waiting to either for a bed or Rookwood. In some instances, they may not be appropriate to go directly to level 1 rehabilitation, in which case they'd have to come back and wait, because obviously what we're trying to do is maintain flow across the system, but do that safely. And in acknowledging those concerns, I know that obviously those specialties to where those sort of high level patients would come back to have some skills to manage these patients, but that would need to be augmented. So we're working quite closely with Jenny Thomas, who's the network rehab lead, to secure some sessions for the health board. Originally, the plan was to put in 4 sessions per week because of the COVID situation and the impact that has had on rehab medicine across South Wales. We will be looking to offer 2 sessions to start off with. That will be a virtual MDT and a virtual ward round per week for the patients that have come back. and that is in addition to the weekly MDT that I think Alistair is already attending, in terms of the patients that are sitting within the MTC that are looking to come back. So we've had some very positive discussions just this morning actually with Martin Bevan, who line manages the respective rehab consultants in Neath Talbot Hospital. We feel actually developing that link with the Neath Talbot group is quite important, particularly for Swansea and West Wales. And so we're just waiting for formal confirmation of that now, and we'll write to Andrew Crothers, who's the SRO of the trauma system in West Wales, to confirm the arrangement shortly, and Rachel and the team will work locally with you to work out how we operationalize that. So I think we're in a better place with that than we were perhaps just as we came out of COVID. I appreciate that it isn't going to be 4 sessions, but we will look to work towards moving towards the full 4 sessions within 6 months of go live.
Great, thanks, Cindy. That's really excellent news, isn't it? A joined-up approach. That's brilliant. Right, I just wanted to thank Maggie's point. Yeah, anaesthetists will transfer. Thanks, Maggie. That's really helpful. Okay, guys. Anybody else would like to ask any questions? Martin, do you want to come in?
Hi. So just going back to the referral pathways, for the type 1 and type 2 patients, we're working on an expectation of automatic acceptance for those patients. Is that right?
Yeah.
But for the type 1, type 2 has a 30-minute window, but type 1 we can arrange transport at the same time as requesting the trauma team leader or referring to the trauma team leader.
You actually shouldn't have to arrange transport yourself. That's a core function of the trauma desk. So by ringing the MTC through the trauma desk, they're conferencing to the call, they're aware of the needs, and they should be starting to arrange that transfer for you without you having to specifically ask.
Good. Okay. Thank you. And then the difference with the type 2 patients, might they just go somewhere else instead of to the major trauma centre? What would be the difference then after the discussion?
I'll possibly ask Dindy to come in on this later, but really that is likely to be discussions around futility to some extent if they need support in that. Otherwise, there will be a general expectation of them going to the MTC. Have we got that reasonably accurate, Dindy?
Yeah, I suppose it's just worth just saying a little bit about both of those pathways. So pathway 1 and 2 are your sort of main acute pathways to access the MTC. Pathway 1, the hyperacute, you would be wanting to share your imaging immediately that CT scan has been done. Okay, so that's heading off to Cardiff. You've then got alongside that your resuscitation of your patient and the concurrent phone call. Traditionally, as you know, you've had to make multiple phone calls to A, get the patient accepted, B, to get a transport modality and potentially a transfer team. What we're trying to do is create a one-stop shop for that element. So when you ring the desk and you say that you've got a hyperacute transfer, and that's the key word, you can say that you've got a hyperacute transfer, the desk will automatically say, right, are EMIRTs available? Yes, they are. Let's get them running before you've even been patched through to the top cover consultant. We can always stand them down later if it's not as given. And then what will happen is if EMIRTs are on way, the top cover consultant for EMIRTs who authorises the transfers and the MTC TTL will be brought in on that call. So you give the story once. And the plan then is they've both heard the story, the patient's details are passed, and then any advice offered from either the MTC TTL or the top cover is given at that stage in order to help you get the patient ready for transfer. So those are the ones that need to go quickly. The emergency transfers, the reason we created a 30-minute window was by exception and not the norm. So the emergency transfers are for patients who are multiply injured, who don't need an immediate procedure in the MTC, but would benefit from MTC care. An example of that would be a patient who's got a chest drain in, who's got also a splenic injury, who's got a fractured femur, for example. Nothing is needed immediately for that patient, but they would benefit from being in an MTC because they're multiply injured. And for that patient group, I've allowed for a 30-minute by exception. So we're not expecting this to be every time you ring them, they go off and have a conversation. And I'm leading on the trauma team leader training, and I'll be certainly saying to them that, it'll be by exception rather than the norm. But it just gives them an opportunity to have discussions around patients who perhaps are borderline, patients with significant comorbidities, and the futility issue that Stuart has raised, and then come back to you. But again, in order to facilitate that being quick, there is a part that you have to play, which is getting those images over to Cardiff the minute those CT scans have done, so that your delay doesn't become a longer delay. And as I said, in the vast majority of those pathway 2 patients, they should just be accepted and the patient goes. But I've allowed an opportunity for them to have an internal conversation for those sort of caveated groups. Does that kind of help in terms of the understanding of those pathways?
Yes, thank you. Yes. So one other thought then, we've had a couple of patients in the last year who've had emergency laparotomy and splenectomy here because they were hypotensive. So that sort of patient, post-operative, are they likely to go to the major trauma centre too, or would they stay here?
Yeah, they would be expected to have their ongoing care in the MTC, and really it's just local damage control surgery to allow that to happen.
Okay, thank you.
And to some extent, Martin, they then become they're no longer a hyperacute transfer, they become an emergency transfer, so you just follow the pathway 2 through your MTC TTL as described.
Okay, thank you. Yes.
You made a point about presumably Burns patients will follow the pathways described.
Well, Burns essentially remains the same pathway in that Morriston for predominant burn injury will be the receiving centre. If a patient presents with a major trauma and associated burns, it's likely they go to the MTC. Can see Dindy's put his hand up.
Yeah, I think just to say that I think Mark's picked up on a really good point. There are some of these nuanced pathways which you obviously got to apply your pathway 1, 2, and 3, but there are some nuances, around cardiothoracics, orthoplastics, spines, pelvises, interventional radiology. Fortunately, we have provided you an infographic which summarizes all those pathways against pathway 1, 2, and 3, but tells you who you should be speaking to. So, for example, for brain injured patients, for mild and moderate head injured patients, we would still expect you to ring the neurosurgeon directly. For severe brain injuries and patients who are intubated with a brain injury, we would expect you to ring the MTC TTL and get that patient accepted either through the hyperacute or emergency transfer pathway.
I think probably worth saying, Dindy, as well, that the trauma desk is there, knows these pathways well. So if you're not entirely sure and haven't managed to get it from all the very good resources available via induction and the website when it's live, there's a point of contact there that can help guide as well.
Excellent. Anybody else have any other questions or points they'd like to make? Scanning it down. Maggie?
Yeah, just to reply to, can you hear me?
Yes, yeah.
Okay, cool. Yeah, just to reply to Dindy's point about ringing the neurosurgeons directly, we have historically, I believe, had difficulty getting our hyperacute head injury patients accepted. Is that something that's been improved with this process?
Yeah, well, I mean, the proof of the pudding, Maggie, is going to be when we get going, really.
Enough.
But I mean, we've what we've said is that for hyperacute emergency transfers for basically head injuries, so those are the more severe end of the spectrum, or patients who are intubated with a brain injury where it's difficult to assess their neurology because they're intubated, they should be in Cardiff, and they should be in Cardiff in an expedited manner. And in doing so, that call is routed through the MTC TTL. So if the patient needs an immediate craniotomy procedure or a decompressive procedure, then that's a hyperacute transfer, and that's automatic acceptance. If they're intubated with a brain injury that needs good neurocritical care, I would expect the MTC TTLs to be accepting those patients, providing that they're suitable for that. Because obviously patients who've got significant comorbidities and things, it may not be appropriate. And I'd expect most of those to be picked up through automatic acceptance. I think for the mild and moderate conditions, because they're head injuries in isolation, they don't kind of fall within major trauma. So we would anticipate you would continue to have your discussions with neurosurgery. But I think they've now provided a mobile phone number that you can call the neurosurgical registrar directly. And certainly my experience from ringing them over the last few months has been they seem to be a bit more accessible through that route.
That is good news. Thank you.
Yeah, we all hope so, Maggie. We all hope so. Great, thanks. That's a good point. Anybody else have anything else they'd like to ask? Give it a few more seconds. Great. Okay. Well, I found this really useful, and I think it's been an excellent presentation. And as Stuart has said, there's lots of resources available. I don't know whether, Stuart, you wanted to have any closing remarks?
Nothing particular, but thanks everyone for joining. I suppose the main thing is please pass the message out, inform colleagues and members of your team that this is going live, and flag to them the pathways and the resources to get them up to speed on what they can expect from the network.
Great, thanks, Stuart. Dindy, did you want to finish with anything?
No, I was just going to say just to thank Stuart and the team for all the work that they've done. We've got a few weeks to go, so I think it's really important that people engage their local teams in what they need to do for Go Live. From a network point of view, we will be dropping off some posters of these key pathways to be displayed in your emergency departments, your anaesthetic, your theatres, and in your critical care environment. So you'll have those available to you in the next couple of weeks. And I think there is also a plan to come and do a bit of a network road show where we can just catch up with people, although socially distanced, however, but to do that in the coming weeks as we go towards Go Live.
Great. Okay. Thanks, everybody. Then I want to thank everybody for the incredible amount of work that's gone into this. I'm sure it's sleepless nights and frustrations because these processes are unfathomably difficult to get up and running. And I'm convinced that this is going to deliver a really good, trauma service for our patients in South Wales, and it's something that we've all been looking forward to for a long time. So thanks very much, guys, and have a good day.